Uh, this talk is titled Infection Mimics, and I'm giving it today at an infection orthocon meeting. It's an approximately 10-minute talk, and the idea is to discuss conditions that look like infections but are not. And most of these cases are or have been presented earlier at bstneoplasms.com. So, this is a 52-year-old who presented with left hip and thigh pain. That's the radiograph, and that's the MR. And you can see the T1 coronal and the T2 axial, etc. And my question will be, and what you need to do is think about this. What do you think is the diagnosis? Now, the X-ray shows a mixed osteolytic sclerotic condition. There's variable periosteal reaction. There's a little bit of new bone or cartilage here. But the MR shows extraosseous spread, but really just looks like cartilage. More importantly, very sharply marginated and no marrow edema. I mean, you could argue that there's just a shade little bit here, but essentially no marrow edema. So this is a cartilage tumor, therefore it becomes a chondrosarcoma, but the radiology report said osteomyelitis. So the orthopedic surgeon went and curated it, put a nail through it. No biopsy material was sent, no organism was found on microbiology, and the patient came back with extensive recurrent disease, eventually needed to have a hip disarticulation done with basically a complete amputation. This is a 65-year-old lady, misinterpreted again on MR as osteomyelitis, but again you can see there is no marrow edema. And what this is lobulated, looks like cartilage, and the biopsy showed chondrosarcoma, but no harm done except for a 3-month wait period during which she received antibiotics. The hallmark of any infection is marrow edema, which appears bright on stir and dark on T1. So this is marrow edema on the stir in the tibia. This is marrow edema in the femur. Um, and this is the dark marrow edema on T1. And you have to match both of these together. Um, you can't just look at the T1 and say this is marrow edema, but when both of these come together, then you know that this is marrow edema. But what is more important is that the absence of marrow edema rules out infection. And so when we look at infection mimics, we look at those without and with marrow edema. Without would almost always be a tumor like chondrosarcoma or metastasis, and with would be these four conditions that you see here. I mean, even LCH is a tumor, but just to differentiate from other tumors. So 8-year-old girl, acute onset wrist pain. You can see this osteolytic subphyseal metaphyseal lesion with marrow and periosseous edema, but no cortical break, no extraosseous spread. I biopsied this lesion, it was negative. Then the patient a week later gave history of pain in other joints. A whole body MR shows multiple physeal lesions in multiple areas, and most of these were asymptomatic. This is classic for chronic non-bacterial osteitis. She was put on pamidronate, and a year later, all these lesions regressed, and she keeps following up every year, and there's no disease now. So CNO is typically in the 9 to 11, or you could say 7 to 14 years age group, and obviously more common in children. And you have to think of CNO when the X-ray MR picture seems to be of osteomyelitis, but the blood work doesn't match, no leukocytosis, often no fever. Imaging will not show a cortical break or extraosseous extension. There may be multifocal lesions in the 7 to 14 years age group. So you have to have this whole characteristic in mind, and then you can try and make a diagnosis. Then we have this condition, which is a little more tricky, right? This patient came in October 14, had this cortical thickening, periosteal reaction, biopsied. We don't have the MR from this time. Didn't show anything. There's progression of disease 3 months later, and the MR shows a focal lesion here. It's a little dark. There's marrow edema. There's irregular periosteal reaction. And so when I biopsy the center here, and this is where you really don't know, is this osteomyelitis? Is this Ewing sarcoma? It turned out to be Ewing sarcoma. Now, there are times when the diagnosis is and the differentiation between the two is simple. So, if you have a large mass here, non necrotic, involving the marrow and circumferential, this is Ewing sarcoma. The only DD would be osteosarcoma. And you have these T1 fat globules here, necrosis in this patient. This is another patient also showing necrotic areas and collections. This is osteomyelitis, and this was Staph aureus in both these patients. The challenge is when you see something like this permeative lesion on the radiograph, ill-defined long segment lesion. So that's the lesion, that's the marrow edema, and you have some extraosseous spread. So is this osteomyelitis? Is this Ewing sarcoma? And short of doing a good biopsy, there is no way to tell what this is. And you can't curate. You have to do a structured biopsy to figure out what is going on. Then we have this entity, 8-year-old, you have this osteolytic diaphyseal mildly expansile lesion with cortical thickening. You can see the focal lesion here, lots of marrow edema, diffuse cortical thickening, and the periosseous edema here on the MR, but there's no cortical break, no extraosseous extension. Now, Ewing sarcoma doesn't produce this kind of diffuse cortical thickening, and so the question is this osteomyelitis or is this something else? And this is actually not atypical for LCH. In fact, it's rather typical. So when you see a diaphyseal or metadiaphyseal lesion in the long bones, young patient, typically below 30, with marrow edema out of proportion to the lesion, you may get cortical break or extraosseous spread in LCH. That's not common though. So when you don't see it, then that's when you think of LCH. Now, similar thing in the 7 to 14 years age group, subphyseal, metaphyseal, multifocal is more likely to be CNO, and you have to be able to differentiate among them. Now, this is a 15-year-old with pain in the left hip, suspected to have TB hip. X-ray showed reduction in joint space, was sent to me for a synovial slash biopsy slash aspiration, and I saw this marrow edema on the MR, but it wasn't on both sides. So this patient doesn't have an arthropathy for sure. The CT, there was some CT done, and I thought there was an osteolytic lesion. So, but nothing matched. So went ahead and repeated the MR, did a dynamic contrast, which showed an arterially enhancing lesion, which was T2 dark, and then repeated a CT, which shows this osteolytic lesion with the central ossific area, did an RFA, and this is an intracapsular osteosteoma. And osteosteomas can do that in atypical or unusual locations, especially when intracapsular, they can simulate infection. Lastly, we have this 86-year-old who had left hip pain for 2 weeks, was admitted for suspected thromboembolism, but she had a little hip pain, so an MR was done. An MR showed this marrow edema, and the report was metastasis versus infection. And a PET CT was done a week later, which showed subtle uptake. And this X-ray was done 1 day after the PET CT. And both the radiologist, who I would expect would miss this, but the orthopedic surgeon also missed this pathology. And I will ask you, what is the likely diagnosis? And this is the list that you can see here. And this is actually a classic tensile fracture along the lateral cortex of the proximal femur. And this occurs with prolonged bisphosphonate use. And then when we kind of put all the imaging together and looked at all of these things, you can see the edema, you can see the fracture, you can see the cortical thickening. This is a classic fracture. Usually the history helps. So this is a marathon runner who had pain in the tibia. We see marrow edema, and you see these areas of cortical thickening. This is highly suggestive of a stress fracture, and that was confirmed on CT, where you see callus formation and this irregular periosteal reaction with callus on the X-ray. But it is the earlier one that can be a problem when you're not aware of what can happen with stress and insufficiency fracture. So our infection mimics can be without marrow edema, which typically occurs with chondrosarcoma and metastases, and this is the list with marrow edema. Most of the times, if we see a focal lesion, a biopsy is a must to differentiate between infection, tumor, LCH, chronic non bacterial osteitis. But if you can see the fracture, as with stress and insufficiency fractures, or if the patient classically fits into CNO and is confirmed by a rheumatologist or a pediatric rheumatologist, then you may get away with not biopsying these. Thank you so much for listening to me.